Namaskar, dosto. Good evening. I am Purnima from Fertility Dost, and I welcome you all to this wonderful platform. Wonderful kiss liye because this is the platform for you all. Women who are dealing or who are facing some issues in their fertility journey or some issues related to conception. So viewers, always feel free to connect with us because whatever you have in your mind, your doubts, and even the suggestions you want to give to other female friends, please feel free to share those on our platform. So today we'll discuss about what we can do to make our conception positive, to make our conception more stronger, because in many cases nowadays we are just getting queries about missed abortions, or we are getting queries about that we have recurrent embryo failures if we are talking about IVF and all that. So we just thought about, okay, let's discuss about what all we as a female or as a couple who are trying to become a parent can do at our end. And we have a very senior doctor with us today to discuss these whole things, these whole issues. And the senior doctor is from ART Fertility Clinics. So ART Fertility Clinic is the knowledge partner for this live. So viewers, I'm just calling our main doctor, Dr. Azadeh Patel from Ahmedabad today on the main screen. And I think you can start pouring your queries related to the main topic. Namaskar, Dr. Patel. Welcome to Fertility Dost.
Namaskar, Purnima. Thank you for having me here.
So, viewers, we have Dr. Patel with us, and she is a clinical head of ART Fertility Clinics, Ahmedabad. So, Ahmedabad people, you can just visit her if you want her special advice on your treatment. She has handled a wide range of fertility issues, we can say, and the main interest of her knowledge or main expertise is for PCOS and poor ovarian reserve. And I think these two topics are the most common things or issues with women are dealing. Either we have high AMH or we have low AMH. I think middle part is still missing nowadays. So, doctor, in today's session also, I would really love to discuss about this poor ovarian reserve also. She has authored and co-authored many national and international articles. So, viewers, in case you want to read more about her, just check on and see the details. So let's start with the session. And as our main topic says, that what can you do to increase the chances of conception? So here we are not marking anything related to natural conception or IVF. We'll just discuss about the wholesome parameters. So, doctor, if we start discussing about the conception thing, we usually talk about egg quality and sperm quality. And nowadays, it is like really easy for me as a patient to know about my AMH, or as a male to know about my semen analysis. So, what you suggest, that what are the parameters which involve both egg and sperm quality?
So, you were talking about testing, which you have already enumerated, mainly AMH and
Right.
semen analysis. Yes, for both the partners. But also, I mean, if you want to really ovarian reserve test, which is very important, ovarian reserve. So, one of the method is AMH, and second is evaluation of the antral follicle count, which can be done with an infertility specialist or a gynac. So that is important. So this is the basic test to at least understand the quality marker for the gametes. So
Right.
yes, yeah.
So, doctor, when we just start our journey, so AMH and semen analysis, we all know. But again, we or doctor cannot comment about the, you can say that quality of egg unless and until we just switch towards the IVF treatment and all that. So, what you suggest at your part, are there any markers? Are there anything related to menses or periodic flow so that we can say that yes, I am lagging behind in this quality.
Yes. So what happens with the ovarian reserve as it starts declining? The first thing to go down would be AMH because that is secreted by the small antral and the pre-antral follicle. So
Right.
first thing to decline in terms of laboratory marker would be the AMH. The cycles of the patient can be still regular with the AMH of maybe zero point 0.5, zero point 0.6. The second thing that goes up is the FSH values, which we check on the second or the third day, which is serum follicle stimulating hormone or serum FSH hormone. So
Hmm.
that will start rising because that is the hormone which recruits the follicle. So higher, I mean, more the value, it shows that it is moving towards failure. So an AMH of zero point 0.2 maybe can have an FSH of 10 to 11, and an AMH of 2 will have an FSH of 4 to 5 in between. So as you can see that with the AMH from 2 to zero point 0.3 it just went down. The FSH from 4 5 increased to 10 11. So that is another marker that we can say, and we have to correlate between them, and also the antral follicle count. So these are the laboratory markers. The second thing, or the patient might give a history. Maybe for her it might be routine because the menstrual cycle might change with the age. So she will probably give a history of short cycles. Say the cycle is not for 30 days or 28 days, it is shortened to 21 to 23 or 24 days or 25 days. So that would be a typical history if we try to ask. She will come up with that, or maybe that she's having less of low. So all this is important when the patient gives this history. It at least hints us that we have to go and look for the ovarian reserve more carefully.
Right. And doctor, if we really have this low AMH and high FSH, then what you suggest as an expert to our viewers?
So now in this case with low AMH and high FSH where the patient is already impeding towards menopause, so that's impeding menopause time. So in that case, time to pregnancy or time to conception is extremely important than anything else. Whether it be a IVF or whether it be a natural conception, pregnancy is at most important. So this is extremely challenging cases in IVF where you have a rise of FSH because things go very unpredicted even with IVF. So in terms of follicular response to the injections, also the dose requirement would be high. The effect on the eggs, it can be detrimental also.
Mhm.
Sometimes we don't get the eggs out of all follicles, so maybe half might be empty, half or maybe full, all might be empty because they will have only fewer follicles to grow. So they will have maybe two, three. So it can be zero eggs retrieved on the day of pickup, fertilization poor, or no mature eggs. Or even if they are mature, the quality might be extremely bad in terms of morphology. As you just correctly mentioned, that AMH and antral follicle counts are not predictive of the quality; they are the quantitative marker. So even if an women with 10 eggs might have a very poor quality eggs, and women with 3 eggs might have a very good morphological eggs. So
Right.
that is the quality can only be commented once we take the eggs out and we are actually witnessing the eggs out in the IVF lab. So for patients like this with higher FSH and poor reserve, those patients go very unpredictable in terms of IVF outcome also. But at least yes, the IVF would give them the best chances than anything else.
Right. So, doctor, what could be the marker of this FSH failure?
Marker. I'm sorry, I could not understand.
As we say that if AMH is below 5, then it is fine. And if AMH is higher than 5 or it is touching 6 or something, that means you are moving towards PCOS. So, is there any marker related to this value marker for FSH also?
It has to be correlated mainly. So if you have a normal responder or a young woman, we
Hmm.
expect an FSH value anything between 4 to 5 only, or 3 to 5, not more than that. So
Okay.
as I mean it will gradually increase. So if a value of 8 or 9 FSH to begin with on the second day is still higher, for a patient even if she has 10 antral follicles and she has an FSH of 8, so that means there's something wrong, that
Right.
she has good number of follicle but the FSH is still high. Maybe there might be some reason or an imbalance or something like that, because FSH is a hormone which starts rising for the next cycle from the previous cycle, last 2 3 days of the previous cycle. So if you are going to get your menses today, your FSH has already started rising for the next cycle almost 2 days back. So when you check on the second day, and if it is a higher value, that means the overeat is trying to push the ovary really hard. So
Okay, right.
anything above 8 or 9 is something where we will say that it is little on the higher side.
Right. So I think next time when you go for AMH testing and all that, you just go and check FSH values also. They are really important in the fact.
Yes.
And doctor, what about semen analysis? We go for three parameters. We definitely check the total count, we check the motility, and the third is morphology. What do you suggest? What should a patient look into these reports?
So yes, you correctly mentioned these three are the major three parameters that we usually check. If anything which is found very abnormal, there are other things that we need to see. So take for example, you have a good count and motility is 0%, right? So that is a case where all the sperms are immotile, where we call them as a complete asthenospermia, right? When we are talking about only motility. Now, in this case, it is important to differentiate whether the sperms are live or they are dead. In this case, because complete asthenospermia has to be differentiated from necrozoospermia, which is all dead sperms, right? Because only
Okay.
the viable or a live sperm will be utilized for fertilization. Dead sperms cannot be used. So in this case, we need to even check for the vitality of the sperms. So for patient, the major understanding would be the count, motility, and morphology. Also in morphology, we just have 4% normal forms out of 100%. So almost 96% sperms would be abnormal. When in case of infertile population, we do see hardly we see any patient having 4% normal forms. It is usually 1%, 2% only where they have normal forms. That is the usual thing that we see. So teratozoospermia is kind of very common in case of male factor, maybe due to various factors, but yes, that is something that we commonly see in IVF clinics, that most of we deal with abnormal morphological sperms. But even if in the morphology, what we need to see more important is whether the, I mean, tail abnormalities will be very more comparatively. But if you have a head abnormality which is excessive, then yes, we need to investigate further. And at least, I mean, in routine laboratories, if you get something like this, if they pick it up, then it is better that you visit an IVF center, because they can at least see the morphology in an inverted microscope, where at least the sperms can have a little magnified image, and there are certain abnormalities. Say, take for example, globozoospermia, where the head are round in shape
Mhm.
instead of the regular shape, and they lack the acrosomal cap. So now these sperms are not capable of fertilization. They cannot enter the oocyte. So if you keep on doing IUI or if you try naturally, that is definitely not going to help. And these are extremely challenging cases, even with ICSI. So that
Okay.
has to be differentiated. So the diagnosis has to be correct. At least I would recommend, if you are struggling with infertility for a very long time, it is better to at least have a semen analysis, correct semen analysis at an IVF center.
Right. I think these things are really, when we talk about the smaller cities or the people who don't have access to good labs,
Yeah.
and yet, they just visit a simple lab and do the semen analysis. So, viewers, please take a note that it seems that semen analysis is the most simpler form of test, but please select the lab very carefully. It is really important.
Yeah, even we
As
get to see, I will just add up, we even get to see that various normal reports previously, and when, repeated checkups, we do see that the count is extremely bad. I mean, with the previous count of 10, 15 million also, and we get to see 1 or 2 million or maybe less than that. So I think every IVF clinic would have so many cases where, the outside report is not correct. Or maybe there can be definitely reduction in the count, but yes, it is better if there is a long standing infertility, a semen correct analysis should be done. It is very
right,
important.
And because at times we just thought कि this doctors said to do the fertility test or semen analysis test from their center only, तो वो तो बस ऐसे ही बोल रहे हैं, रिपोर्ट तो मेरे पास है, बट
Hmm.
ऐसा प्लीज नहीं सोचिए, वो आपके फायदे के लिए बोल रहे हैं,
Yeah,
बिकॉज
correct.
रिपोर्ट्स हैं, बट वो रिपोर्ट्स हो सकता है करेक्ट ना। So, doctor, we have one query related to this varicocele condition. So, what exactly is this? Because the lady mentioned that doctor diagnosed her husband with this. Please specify, is it possible to have a natural conception with this condition?
Okay, so varicocele is dilatation, or um, the testes are located in the scrotum, right? The scrotum is the sac or the male organ that we can see apart from penis, the testicles. The skin covering the testes is called as scrotum. It is the whole sac, and the testes is located within. Now, the veins of this sac, if they get dilated due to any reason, say, take for example, if the pressure is very high from the abdomen, they can still dilate, right? So, I mean, they get full of blood. So, in
Okay.
that situation, what would happen is that the temperature inside the testes, which is located inside the sac, will increase. Now, male organs or the testes, it is located, or the gonad as we correctly say, is located outside the male body for a reason, because they are not located within the body, because it requires little less temperature to produce sperm, right? So when this veins surrounding it gets dilated, the temperature within the testes also rise. So in this case it can affect the spermatogenesis process, that is the process
Okay.
which generates sperms, right?
Hmm.
So what we need to see is varicocele, what is the grade? So there are four grades: grade 1, 2, 3, and 4. So grade 1 is usually diagnosed by an ultrasound only, the patient will not have any symptoms. Grade 2, grade 3 are kind of common, and grade 4 varicocele will impact spermatogenesis more. So in this case, what we need to see is that if you have varicocele, what is the semen analysis? Whether even a grade 2 varicocele has affected the semen analysis or not. So if you have a grade 3 varicocele also with a semen analysis absolutely normal, then probably it doesn't need any treatment. More or less with the varicocele, the first thing that it will affect is the morphology of the sperms.
Okay.
But if the count motility is good enough to compensate for that, then nothing to be done. Now, for varicocele, if it is correctly diagnosed, then there are options. I mean, we really have to see what is more important, correcting the varicocele or getting the patient pregnant,
Right,
right? So
right.
for pregnancy, we have to see a lot of parameter. How long have they been trying for? What is the age of the female? If there is any other causes contributing to infertility or not, and what is the treatments that they have already got done. So it depends on the choice of treatment will depend on a lot of parameters. But if the patient already has a previous child secondary infertility 2 3 years back diagnosed with varicocele, then probably we don't do anything for that.
Right.
So
Right.
there are surgery also available. You can get it corrected, but there would be at least 5% risk that it might go wrong and reduce the count drastically. So it should be chosen wisely based on your semen analysis and the complaints.
Right. So I think if you are in this session and you are listening the session, so please take a note. डॉक्टर से आप खुल के बात कीजिए, आप पॉजिटिव नेगेटिव इस ट्रीटमेंट के क्या आएंगे उसको डिस्कस कीजिए, एंड देन यू डिसाइड टू गो फर्दर, बिकॉज वी नो कि कंसेप्शन ही मेजर कंसर्न है यहाँ पे आपका, तो आप चीज़ों को लाइटली ना लें और ये मत सोचिए कि ये अपने आप इसका हल निकल आएगा, बिकॉज इट इज़ नॉट पॉसिबल. You really need to visit the doctor, and we would say that right doctor, or you can visit Dr. Patel also, check with her, connect with her, and if you want you can share your number with us and we'll directly connect you with the doctor. So doctor, uh, patients, or we can say that we have many cases nowadays where it seems that early miscarriages are really common. So is it due to stress, due to age factor, or again we can say that gametes are of bad quality. So we have many queries related to this. What could be the reason for uh, implantation failure, or we can say that what could be the reason for early miscarriages?
So, with this, the miscarriages are broadly divided into early and late. Here we are talking only about the early miscarriages,
Okay.
which are less than 6 weeks, 6 to 8 weeks, or maybe less than that. So, that is early miscarriage. Now, early miscarriages would be because of the implantation of faulty implantation or a faulty placentation process, which the placentation process at least takes 12 weeks to complete. So at
Hmm.
the end of third month, it gets complete. So if the placentation process does not go correctly by the embryo, majorly, because it
Hmm.
is at fault, because it is not formed correctly, it will obviously fail. It is a weaker embryo because it is not good embryo. So it will not go ahead with that process very correctly and it will fail. So early abortions are mainly 75% of the time due to embryo aneuploidy. That is, the embryo is not formed correctly in terms of its chromosomal number, right? Now, this is majorly because of the egg factor, most common, because
Hmm.
half of the gamete, half of the chromosome come from the mother or the egg, and half come from the father or the sperms. Now, these sperms have a different process of reduction and contributing the half of the chromosome. The egg already has that full number of chromosome, which goes ahead with reduction at the time of ovulation, right? The sperms are formed half already, but the egg goes ahead with the reduction at the time of ovulation. So if that is not done correctly, which we term as meiotic non-disjunction, then maybe one or two or three chromosome might fail to separate from their two ends to separate to become half. So in that case,
Okay.
whole chromosome would go ahead into the egg. Now, this egg gets fertilized with the half bearing the sperm which is carrying half chromosome. Then of course there's one extra chromosome in the egg, right?
Right.
So
Right.
most common is say we have like 23 pairs of chromosome in all our cells because we bear 46 chromosomes in total. So it is 23 into 2, 46, right? So we have 23 pairs of chromosome. So with the egg, most commonly what is seen is a non-disjunction on chromosome number 21. So
Okay.
instead of half, it is one full chromosome, and then there is 21 half from the sperm also joining in to form the embryo. So then it would
Right.
be three chromosomes on the location number 21. So that is called as trisomy 21, which is very common.
Very
And we call
common.
these babies do come in the world and they are called as Down syndrome babies. They do, it's a viable anomaly. So, I mean, very well now we can even detect it early in early pregnancy also. But that is very, very common and that is majorly due to the egg factor. So, if the eggs do not reduce themselves correctly, then the embryo, resultant embryo, of course, will not be good. Now, the nature will try to prevent the anomalous child to come to this world, right? So, this is their way of stopping the pregnancy. So, either they will not contribute to pregnancy, it will not result into the pregnancy, or if it results, if it goes ahead with the implantation or implantation process, then further later on it will realize that it is not correct, and then there would be stoppage of the life at any stage, and then there would be abortion. So the early abortions that we see are mainly due to embryonic factor. For some reason, maybe multiple chromosomal abnormalities or any genetic problem in the embryo might have resulted into not correct embryo. So it is the nature who decides and which embryos to come to this world. So if they are not formed correctly, it will result into abortion.
So, doctor, what could be the early diagnosis or early test that you suggest for such patients?
Now, the earliest, I mean, sadly, if the patient has conceived naturally, the earliest that we can see whether the pregnancy is normal or not, or the child developing inside seems to be normal or not, majorly, is at the end of third month. So there is an NT scan, which we say the knuckle translucency scan, which happens at 11 to 14 weeks of pregnancy. That is the earliest detection by an ultrasound. If there's any abnormality or a doubt about something, we can go for NIPT testing from the mother's blood, which is non-invasive prenatal diagnostic test, where at least this common anomalies can be picked up with a great accuracy. So that is usually advised. But in case of patient having multiple abortions, early abortions, where there is a suspect, we go ahead with there's a whole list of investigation which we go with. We advise to the patient along with the blood test and the karyotype of the couple, just to see if their karyotype or the chromosomal structure are normal or not, because chromosomal problems can be numerical and they can be structural also. If the how do I explain, if the chromosome structure is not correct, it will also result it will result into the faulty embryo, and that will also have a higher risk of miscarriage. So just to see if the parental karyotype is normal or not, and if we find something, then of course there's very less thing that we can do, but at least with IVF we can offer them prenatal genetic testing before putting the embryos back, specifically for aneuploidies, also for any structural rearrangement, if we have to specifically look for it, or even if there are certain anomalies or translocations which have a very high risk of abortion. In that case, of course, the gamete donation can be advised, at least can be given as an option, if there is no other factor also contributing to abortions.
Right. The proper diagnosis is really important in each and every case. And if you are having this recurrent failures, then please do talk with your doctor, do consult related to genetic testing and other things. Doctor, usually we have, I don't know whether it is a myth or it's a fact, ओवरवेट है तो डॉक्टर सबसे पहले कहते हैं प्लीज वेट कम करके आइए. तो वी हैव फ्यू क्वेश्चंस दैट हमने तो देखा है ओवरवेट लेडीज को प्रेग्नेंट होते हुए, बट व्हाई डॉक्टर इज आस्किंग मी अगेन एंड अगेन प्लीज गो बैक एंड रिड्यूस योर वेट.
So now this is very important, and we do see that the incidence of obesity has gone up in last decade because of the eating habit. It's mainly due to habitual uh, sleep patterns and all of it. The weights have gone up, and also the hypothyroidism is also something that is coming up.
Right.
Now, in when we have a very higher weight women, in that case, it has an impact on the ovulation and the follicular genesis. Also, higher BMI can also be due to underlying some issue. Say, take for example, thyroid. Now, thyroid hypothyroidism, where the TSH levels are very high. In that case, the women will have tendency to gain weight, and she will be obese. And thyroid is also one of the very important hormone which plays a part in follicular genesis and the ovulation. It is also very important for the male partner. So if the male is hypothyroid, then it can also affect the semen count and reduce the count. So as soon as there is a correction, things start settling down in terms of the gametogenesis. But weight itself can be an independent marker for faulty follicular genesis, ovulation, and if there is pregnancy, then it is an independent risk factor for abortion. Also,
Okay.
what I tell my patients who are really very obese is that before pregnancy, if you try to lose as much as possible, because this is the time you will be a little aggressive and you will try to lose weight. Because post pregnancy, postpartum period, there's always a weight gain of 10 to 14 kgs, which will just add up and make it more difficult. Also,
Right.
this obesity is as such a very high risk factor for other medical disorders, which will be very, even in pregnancy also. So hypertension, diabetes, you are already at risk for all of this. So if you are young and if there is a serious advice on weight loss by your doctor, take it very seriously. It is not that the obese patients don't get pregnant naturally. They do get pregnant naturally, but every patient, every human body is different. If you are
Right.
struggling, then of course weight loss will only and only help. It is not that losing weight and you'll get pregnant naturally. Might not happen. You will still need treatment, but it will be just advantageous overall in terms of treatment and later in pregnancy.
Right. Doctor, you just mentioned about thyroid, and we really know that it's on higher range. I think 6 out of 10 will be having these thyroid issues, and it is more common in female rather than male. So, what we can do to diagnose it early? Do you suggest regular checkups, or if we are on medication, so how to proceed with this medication towards the pregnancy?
Yeah. So what happens with hypothyroidism is that it will not give you any symptoms. If it is, in early stages, it will not give you any symptoms. So a patient with a TSH of 10, 12 might be roaming and they would be feeling that मुझे तो कुछ नहीं है, I have no problem. It's just a blood test that has come abnormal. But later, I mean, if it is ignored, then of course they'll start feeling all the symptoms, which is sluggishness, they'll start having weight gain, excessive sleepiness, all of it, etc., etc. And controlling thyroid in pregnancy is extremely important because there's something called as neonatal hypothyroidism, which affects the child in pregnant women. So the cutoff of keeping the thyroid or the TSH value is extremely low in first trimester of the pregnancy, that is in the first 3 months, where we
Hmm.
like to keep it less than 2.5 to avoid any detrimental effect of the maternal thyroid hormone on the child, right? Because that
Okay.
can result into the nervous system, the development. It can affect there, and it can affect the
Okay.
IQ of the child. So that is something which is very important. So it, of course, it's just a blood test, and the good part is that control of hypothyroidism is also very easy when it is less, right? So, I mean, a TSH of 10 can be easily controlled with supplementing the thyroid hormone or the thyroxine hormone in 50 to 75 microgram, where it is just a single tablet which has to be taken on empty stomach as soon as you wake up early in the morning. So you just keep it on the bedside, take one tablet, have it with water, and you are done. I mean, that is all what needs to be done. But it is very, very important to control that TSH level because it will also decrease the egg quality. If you are female, it will also impact the egg quality and impact the
Okay.
ovulation also, and will pose difficulty in conceiving and later during the pregnancy.
Right. So I think thyroid is very common,
Yeah, it is very
common thing,
yeah.
and even lately I think कुछ महीनों तक हम फीमेल्स में ज्यादा सुनते थे, बट इन recent 4 or 5 months जो हम लोग सुन रहे हैं, आई एम नॉट टॉकिंग अबाउट के स्टडीज हुई हैं इस पे, बट मेल्स में भी दिस इज ऑन like on rise. Males are also
Yeah,
complaining about this.
yeah, yeah. And later also it has a risk of developing hypertension. So of course it's
Okay.
all interrelated, so it's better to control. And for patients where we have an obese male with a little
Hmm.
compromised semen sample, we do go ahead testing it. And correction of hypothyroid, if found, if diagnosed, correction of hypothyroidism might also make a lot of difference for him also.
Okay, right. Right. And one very important thing, doctor, what about the medication part? Because the people at times they say कि हमने टेस्ट करवाया कम हो गया हमने मेडिसिन छोड़ दिया 2 months के बाद फिर करवाया बढ़ गया तो I really want this input from your side.
Yes, so one thing that everybody needs to understand that if the thyroid goes down, if from very high level, if it has come down, it is only
Hmm.
because of the medication. Yes, you can stop the medication and see how you are behaving, but you need repeated checkups, every 2, 3 months just to check whether the levels are going high or not. But it is very less likely that with a very high level of thyroid and controlled by the medication, and as soon as you stop, things will be fine. No, I mean, if you're put on a very low dose, say 25 microgram or 12.5 microgram, just to keep the levels under check, because what if you see the laboratory test, they usually mention that less than 4 is normal, less than 4, 4.3 it is normal. But for patients who are trying to conceive, or for women specifically, or for women who have abortions, we like to keep it less than 2.5. So even if you have like 4, which is usually into normal range, if you're not trying to conceive or any abortion, it is fine. But if you're trying to conceive, we will add up some medication. We'll add up little dose so that it comes down below 2.5. This is what we want to keep. Because in the first trimester, if you conceive in pregnancy, also there would be little shoot up. So that will just increase the TSH level, where you might have an increased demand to increase the dose of your medication for short time, so that it doesn't affect the developing child. But so it is very less likely, I would say, that value of like 4 or 5 might be controlled. Yes, there is dietary contribution also, and endocrinologists do they advise on it, but at least try to keep less than 2.5 if you are trying to conceive. So don't believe a value of 3.7 might be normal as per laboratory parameters, the reference range. It might fall into the normal reference range, but for us, it is little bit higher. You might need correction.
Right.
So don't
So
stop it. Yeah.
right. Please, doctor.
Yeah. So you need to, test it every 2, 3 months just to see that if it is under check.
Okay, I think this is very important to recheck again and again your values. So, if you are in this beautiful journey of parenthood, please make sure that you do your test regularly and make sure that you meet the right doctor at right time of your trying for conception. And if you are in Ahmedabad, please do visit Dr. Patel, or if you are in any other city of India, ART Fertility Clinics has many centers all over India. Please do connect with us. Or we have the number, telephone number mentioned in the comment section. Please make a call. आप डायरेक्ट भी जाके मिल सकते हैं डॉक्टर से. बस इतना कहना है कि आपने उनका सेशन फर्टिलिटी दोस्त पे देखा था. So it will create a magic for you. So thank you, Dr. Patel. Thank you so much for joining today. In North India, we are having this Diwali rush. So, happy Diwali to all our viewers and to you, Doctor. Have a wonderful day. Thank you.
Thank you so much, Purnima, and happy Diwali to you and all viewers. Thank you so
Thank,
much.
thank
Thank
you.
you.